coming to the hypermobility EDS, so that was the challenging one, because that's the one where we had to really put a lot of effort, because we don't have tests to confirm it, not like any other types. So we had to really rely on a set of description and a very strict criteria, hoping this will help researchers in the future, and also help us to find, for example, a gene for it and confirm that this is actually a connective tissue condition. So there are different criteria. There are three criteria, and to make these diagnoses, you have to have all of them, 1, 2, and 3. The first one is we need documentation of a generalized joint hypermobility. I'm pleased to report that we're still using the Byton criteria because it is very reliable, it's very quick, it's easy to apply, and it wouldn't be too much for rheumatologists or for GPs to apply it in a clinic setting. There's no point of putting another type of a test that will take a long time, because no one will apply it. So for the generalized hypermobility, for adults it will be more than 5. For people who are above the age of 50, which I call when they're wiser, so when we're wiser we can accept more than 4. Historical hypermobility, we do take that into consideration. So if you've got the 5-point questionnaires, and I'm very happy to take questions about that, if someone doesn't know what is it exactly, we can add a point. The one which is very, very important and significant, that there is something for children and adolescents in this criteria, and that is to say that they need a hypermobility above 6. And by doing this, we're hoping that the pediatricians will come on board. So the first one, you need to have a confirmation there's generalized hypermobility. The second one, this is a little bit complex, but basically you've got 3 features. And of these 3 features, you have to have 2 at least. So the feature which is very common, or like very logical, is to have musculoskeletal complications in terms of pain or instability. The second one is positive family history, but it has to be the 2017 criteria. So this would work for the future, not for the past. So if there is a family history of EDS, hypermobility according to 1997 criteria, it wouldn't be taken into consideration here. The one which is very important, and it was again a major step, is these systemic manifestations. There are a list of 12 different things, and it was decided that if you have 5 of them, you will be in the category of the hypermobile EDS. For example, the skin has to be quite soft, stretchier than normal. You will have extensive stretch marks without weight gain. For example, pelvic floor prolapse without pregnancies, recurrent abdominal hernias, lots of symptoms and signs that will tell us that the connective tissue has been altered, because that's the only way of getting everyone to agree that there's something else is going on in these group of patients. So for example, it's just the pictures, recurrent abdominal hernias, prolapse. There's something called pysiogenic papules. This is very common in a normal population, but anyway, it's a minor feature, and if it occurs with other things, it can be taken into consideration. We're talking about marfanoid body habitus and also abnormalities on the echocardiogram. The third thing, which is very important, and this is again the first time to be included, is we have to make sure that these patients do not have other conditions such as neuropathy, myopathy. We've got quite a few patients where they're coming along with extreme flexibility of the joint, but the problem is not the joint themselves, it's actually the muscles or the nerves. So we have to make sure that they don't have an underlying cause, medical cause, to cause the problems with the joints. So coming back to the lovely slide from Dr. Hakim, as we discussed initially, the top one is what we would consider in the hypermobility syndrome according to the Brighton criteria. The bottom will be the EDS 1997 criteria. And here we are. The question was, we all felt we can't have all or nothing. We can't just have hypermobile EDS and everyone else is nothing, because clearly there are people who are hypermobile, they've got issues, and there is pain, and they have some functional features, but not to the level where you say this is the hypermobile EDS. So that's where the new terminology, which is the hypermobility spectrum disorder, came to light. And I want here to say, again, it's the hypermobile EDS or hypermobility spectrum disorder doesn't mean one is more severe than the other, one is more significant than the other. It's just it's just something different. So we do have people who have, sometimes even the hypermobility don't correlate with the level of symptoms. So that's very important for anyone in the room to know that it's not one is more severe, because sometimes when you say this is hypermobility spectrum disorder, as if he's not taking things seriously, or maybe you're not going to have the medical attention you need, and that's not the case. The management plan is exactly the same. The other things which I read to reassure people, that's we're not undiagnosing people according to 1997 criteria. The idea, this is a work for the future. So if someone is already being diagnosed, yes, that's perfectly fine. We respect that. You will continue to be a hypermobile EDS according to 1997 criteria, but wouldn't be in the research project that will be for the future. That's the only difference. So to combine things together, in one slide, in the early 2000s, we talk about EDS3, joint hypermobility syndrome. Then they merged, and now they merged for a good reason, for management plan, and it worked, and we know how it works. Created a problem in terms of research, and now we're looking at two different conditions, the hypermobile EDS and then the hypermobility spectrum disorder. So the hypermobility spectrum disorder is basically more or less people with hypermobility, pain, instability, other features, but they just do not fulfill all the criteria that we discussed, which is quite a tight one, and we will be looking at that next year in 2018. Again, apologize, the pictures are small, but you can have access to these papers. And we describe now the hypermobility. We're looking at it as more of a generalized one, where the Brighton score is more than 5, or it could be peripheral, which is only hands and feet, which we see it mainly in children, for example, or you can say sort of more localized when it is less than 5, the Brighton score. And again, that will be more of a research tools and looking at outcomes. You might have seen that. I can't get that clearer. That this is the EDS checklist. This is what we use in a clinic, and is being used in not just in the UK and across the world. And we're all making sure that we're sharing this with everyone who's looking after people with hypermobility. So basically, it's just to summarize what is the criteria. As you can see, there are 3 sections, and at the bottom it will say, will this person be classified as hypermobile EDS, or will it be the hypermobility spectrum disorder? And something like that will be used for register in the future and also for research. So if you look at some of the papers that is being published, I just want to say that at the end, I've got 5 minutes. So it just to say that the papers, as I said, it's the Brighton score was, the Brighton criteria was too inclusive. Too many people were in the same category, and the classification was here to clarify who would we call hypermobile EDS for future research. And again, Alan and Mark Castori have recently published an amazing paper to trying to clarify the thoughts behind the hypermobility spectrum disorder. And that's really is recognizing that we're describing the symptoms rather than giving a specific diagnostic criteria. There's no doubt the feedback, certainly from the specialists and for the doctors around the world, from even the most, the people, the non-believers, as we call them, they've been very, very positive. We've had a very useful meeting with one of the top pediatric rheumatologists last week, and after an hour and a half of discussion, he said, "You won me." And it was, I was almost like in tears. It's like, finally, they're going to listen to this. I just want to say that both conditions are associated with other symptoms, such as pain, fatigue, postural, like POTS, autonomic dysfunction. You have gastrointestinal dysfunction. So again, one of the problems that happened in the past, if you're in the EDS, you'll have this. If you don't have it, that means you're not an EDS. That's not the case. Both conditions, you will have these systemic manifestations. tell this was Alan's slide. Okay, so so if we want to think about, there are 2 disorders, but there are multiple symptoms, and there was a question is why we didn't include some of these features in the diagnostic criteria, because so far we don't know if it's part of the condition itself or it's an association, but it's definitely a work in progress. So what's the future? Certainly at international level, this has not stopped. We are sharing this new criteria with all specialists around the world. We're gathering feedback about, is it workable? Is it something that could be used in the clinic? Could the GP use it? And also, we are going to establish an EDS registry and use that for research. And of course, we're all very excited about having the next meeting in Ghent 2018. About the UK, and again, I'm going to be very, very brief. A lot of work with the 2 charities put together. They are involved, and they are in the heart, not just involved, they are in the heart of this new diagnostic criteria. They certainly were present in New York, and they will have patient representation. Both of them are working with the consortium for the future. And I think you will have, I'm hoping that in the next 2 to 3 years we'll come back and tell you about the results of the Ghent 2018. Thank you very much for your attention.